Good afternoon, everyone. I'm Steve Handelman, the Director of the Center on Immediate Crime and Justice at John Jay College. I want to welcome you to the opening program of our three-part webinar series on justice and the pandemic. It's an issue that I'm not even sure where we can start. There's so much to talk about, and we can barely, I'm sure, cover it in just 3 sessions. But I want to ask and thank all of you for joining us. We've got a very large crowd coming in of journalists who are eager to participate in our sessions, a number of really exciting speakers. And I first, of course, want to thank the Langeloth Foundation for supporting this program. It is part of the series that we have been doing with Langeloth on the correctional health in the U.S. We've had several programs with them over the course of several years. And of course, with COVID, it adds a special dimension that nobody could ever have anticipated before. Some people would say it offers an opportunity to really rethink how we do correctional justice as a whole, as well as the justice system. So without further ado, I want to get into it. Our journalism coordinator for this program is Katti Gray, who most of you know well. Her bio is in the materials that you've been sent this morning, as well as the agenda. And Katti will introduce our keynote speaker and some of the themes that we're going to be addressing today. So Katti, over to you. Katti, your audio is off.
Good morning and good afternoon, everyone. Thank you so much for being here. Thomas Weber's a longer bio is, of course, in the program, but briefly, he is CEO of PrimeCare Medical, which provides healthcare to 80 facilities across 5 states. Before that, he was in private practice, dealing with entities including eye healthcare providers. We are delighted to have him today. Tom, over to you.
Thank you, Katti. My pleasure to be here. One of the things I want to do at the inception of the discussion is encourage all participants to ask questions. I would rather share with you the information you're looking for instead of assuming what you want to hear. So please use that chat room, and I'll try to my best ability to answer any questions you may have. As Katti mentioned, PrimeCare Medical provides services in 80 facilities. We take care of, pre-COVID, about 25,000 lives a day. During COVID, that has dropped down somewhat, but is inching back up. We provide care in county correctional facilities as well as juvenile facilities. We do not provide any care in Department of Corrections or state facilities. So our patients are either pretrial detainees or those who are sentenced to a shorter period of time, 2 years or less typically. So what I'd like to do today is go over essentially 3 subjects. The first being the difficulties, our experience that we've experienced with dealing with COVID in the facilities, provide you some statistical information, as well as just some of the anecdotal hurdles that we've encountered. And then 2, give you an explanation or an oversight of what we are currently doing. And then 3, wrap it up with some recommendations of what we can do moving forward. In terms of the difficulties that we're facing, everyone's familiar with some of the challenges from congregate housing, lack of social distancing. But one of the concerns that we have generally in correctional healthcare is our patient base tends to be have a higher acuity of health concerns than the general population. Unfortunately, a number of individuals, high percentage of individuals who come into a correctional facility can be battling mental health issues or substance abuse issues, and have been doing so for a number of years, so that their physical stature is much older than their chronological age would portray. And that obviously plays an impact, as we've all heard, in terms of who are the most vulnerable in this pandemic. It pushes the percentage of those in a correctional facility significantly higher. Also, a lot of our patients have multiple or comorbidities or different matters going on, and plus have not, unfortunately, had the means or the ability to obtain care in the community, so that, again, their health is compromised. So one of the first hurdles is just our patient population. The second, and perhaps the most significant, is the lack of clear guidance on how we're supposed to deal with this pandemic. I'm not here to make political statements or express a political view, but the lack of clarity has produced a division in our population as to how to handle this, and that division creates again hurdles into appropriately treating it. In addition to that clear guidance of what we should be doing, there has been a difference of opinion, or excuse me, there have been changes in the protocols that we're supposed to follow. At the beginning of the pandemic, mask wearing was not recommended or required. And as you all know, that has changed now. The same with testing. At the beginning, you were only testing symptomatic individuals, and most likely only symptomatic individuals that present with the comorbidity. Now, testing is much more prevalent and is an excellent tool to help us prevent COVID from coming into our facilities or maintaining it once it becomes into our facility. One of the challenges we face as a healthcare provider, and if you think of your own life experiences, I'm sure you're familiar with individuals who do not follow the medical advice given to them, whether it's someone who has hypertension, not losing weight, or not taking blood pressure medications down the road. But we can only give recommendations. And this includes the recommendations that we are giving to address what is going on with the COVID. By this, I mean, we can urge everyone to wear a mask in the facility. As a company, we can mandate our staff to do it, but we can't for the security side of the building or our patients. So those pose problems and increase the difficulty we have related to social distancing. Likewise, we can make recommendations to the facilities to control entry into the facility by third parties, but that is outside of our control. And that's one of the areas that I know raises a lot of controversy, because just because we're in a pandemic doesn't mean all the other difficulties and problems that we face in a correctional setting went away. So I know there is concerns raised when we stop visitation or recommend that visitation be stopped, but you're trying to counterbalance what impact that has on our patient versus the risk it poses by increasing the likelihood that the disease may be introduced. Same with group programs. We unfortunately had one facility where we had a minor outbreak of COVID, and it was directly traced back to a clergy member. Once some of the restrictions were relaxed and facilities were allowing third parties in, came in to conduct a group session, and unfortunately ended up certainly unintentionally, he was asymptomatic, but caused the introduction into the facility. As I'm sure you recognize, we still go out in the community. You go into an establishment that says masks are to be worn, and someone will walk in without a mask. And there are concerns on how that is to be addressed. Do you say something? Does the store require them to leave? The same type of problems exist in a correctional facility. Despite the risks present in a facility in reference to a infectious disease spread. There are some aspects of the facility that actually can make it safe. If you think of what the NBA did in terms of encapsulating everything in a bubble to control the spread of the disease, a jail is a confined bubble. And at the first go around in March, we saw a lot of areas take the steps of releasing certain inmates who are at high risk, not incarcerating individuals, but looking for diversion programs, stopping work release, stopping weekender programs. And that was effective. And likewise, since we can control housing, or not us, but security can control housing, we can make recommendations that if anyone is coming in, they either be tested or placed in quarantine, or ideally both. And if you have a facility that is COVID-free and you're doing that testing and quarantine, you're significantly limiting the exposure to our patients. It is now limited to potential exposure from our staff or security staff. However, once we were relatively successful in addressing the pandemic in the spring, everyone was in a rush to get back to normal. And what that means in correctional is you incarcerate more people. The population went up. But in addition to the population going up, you open up more. You allow visitation from attorneys and family members. And certainly that is necessary for the patients and their well-being. Obviously, this pandemic has had a significant impact on the mental health issues being presented within the facility, and we need to be very cognizant of that. What we've seen with this spike or steady increase over the last several months is the steps that were put in place were reversed. And it is not surprising that we are seeing the kind of numbers we are now. In terms of, mask wearing, one last point on that, we can trace every significant recent outbreak of the disease to a facility wherein the wearing of the masks was not as stringently enforced or followed, I shouldn't say enforced, but followed by everyone in the facility. And that has led to the increase. Other problems that we're facing in correctional healthcare is outside providers are refusing to see our patients. In a correctional setting, particularly in a county setting, the type of care available to our patients is akin to a community family doctor practice or a family mental health psychiatrist practice. We don't have the ability to do surgery in those facilities, nor would you want to conduct surgery in there. Once they had issues with the pandemic in the community, we had people who were to be sent out for consults, people who needed care beyond the level that could be obtained in the facility, and their appointments were being canceled by the outside providers, sometimes in very serious situations. And all that leads us to just trying to plead and advocate on our patients' behalf of the necessity of doing this. And if all else fails, calling an ambulance and having the individual transferred to the emergency room, not unlike what some individuals who don't have health insurance will do to take care of their problems. In addition to those consults being stopped, a lot of community mental health programs and groups were put on hold as a result of the pandemic. So we were seeing individuals who were managing their mental health concerns or situations fairly well out in the community, but those treatments were no longer available. And we've had individuals who can control or address their behavioral health issues very well with combinations of compliance with medications prescribed, as well as therapy. And when those are removed or prevented from being obtained in the community, it can lead to a rapid decline in the individual's health, and in some situations result in them acting out in a way that unfortunately results in them being incarcerated. There needs to be a greater acceptance of mental health illnesses as a sickness by our society as a whole. It is the only disease that I know of that you could go to a hospital with a recognized diagnosis and the condition gets worse, and rather than intensify the treatment, they will arrest you and have you placed in a jail. And by that, I mean, if someone comes in and they're combative and they would happen to strike a healthcare provider in the hospital, oftentimes that will result in charges being brought, and the individual is taken out and transported to a jail. I could not imagine any scenario under which someone would walk in complaining of chest pain and then go into full cardiac arrest, and rather than receive the treatment they deserve and need, be transported out of the hospital, let alone to a facility. Another thing that we have seen is a increase in the level of abuse that a number of our patients are suffering from. And disproportionately severe alcohol detoxification, which obviously presents a significant risk to the patient, and we've seen a spike in that. Some of the changes we had at the beginning, we had patients who were asking for tests when all of the indication was you don't test everyone. Individuals, I think some were doing this in hopes, ironically, that they might be positive, and that positive test would lead to being released from the facility. We've seen a change in that of late, where a number of individuals are reluctant to report symptoms or submit to a test because they fear the ramifications that come with that. And some of the ramifications that come with that are driven by us, and others by other patients or inmates. By us, we will then quarantine people. It will limit movement and out time from their cells, and individuals, understandably so, don't enjoy going down that path, yet it's required for their safety as well as everyone else. Also, from other patients or inmates, we've seen instances of retaliation or altercations between inmates because someone believes that someone else exposed them to the disease. Moving on to the second point, what are we doing to combat this? I know it's been posted, and just encourage everyone to go to our website. We created a specific page for COVID that details the steps we're taking, directions we're giving our staff, as well as our clients on how we want to manage this. In terms of more 20,000 foot view, as a result of the SARS breakout in 2009, we fortunately had a rather robust pandemic policy in place that we, based upon the recommendations at that time from the CDC and from WHO, we implemented that at the beginning of February, long before there were any instances any known instances, I should say, in any of our facilities. And we've been following that and making modifications to that. We have increased surveillance of our patients. Temperatures are taken of everyone at least twice a week. Individuals that have been exposed would have their temperatures taken twice a day. We are also taking the temperature of all our staff, also security staff coming in, and have developed a short ILA screening form, which if any of you have traveled into any government buildings, you're probably familiar with it, where they'll ask about temperatures, travel, close contact with anyone or any symptoms. As I mentioned, we've provided masks for all our staff, as well. The counties are providing for their security. There was concern as to availability. Fortunately, in all of our sites, I'm unaware of any ability to obtain adequate PPE. A lot of the counties and governments have taken advantage of the CARES Act to obtain these materials for themselves and the inmates.
Tom, if I might interrupt for just a second, how about five more minutes, because the questions are coming in for you to do the 2 and 3. Thank you so much.
Yep. So as I mentioned earlier, we quarantine all new patients. We've recommended, and the facilities are following, when you're allowing out time, they be in smaller groups, and they be the same group out at the same time, so you can not infect as many. We recommend that the COs stay on their same shifts and same areas, so they're not potentially infecting other areas of the facility. We have providing much more care out on the units, so that there is less movement in the facility. Our staff will go out to them instead of bringing down 10 or 12 patients to us in a reoccurring cycle. This does pose some concerns from a HIPAA standpoint, as well as the willingness for the patients to be as candid or open with staff. If there's a concern, they're not in a medical area. As I mentioned, we've done testing, some statistics. We've done approximately 50,000 tests company-wide. Our percentage of positives is right around 7.5%. And to show you some of the disparity in the area, in different areas, in West Virginia, it is less than 1.3%. So there is great variance in where the disease has prompted or shown up. Also doing the education and having the facilities implement daily or more frequently cleanings of high touch areas or high traffic areas. Also, if a patient does have to go out of the facility for a consult or for court, when they come back, we've recommended and they're implementing that they have a shower, they get a new set of clothes, and they are monitored more closely with the daily temperatures. Things we can do. First and foremost is take this seriously. Hopefully, as a society, we're in the process of learning a lesson that if you just ignore this, it's not going to go away. So unless you are a believer in the herd mentality, it's going to take actions from us to help control this. The vaccine, we're hearing promising news from that. We are one of the targeted areas to get the first dosage. At least our staff is in the first group, and then our patients with higher risk factors would be next. However, we have a concern as to the availability of enough vaccines and how they're going to distribute them through those different groups. Also, they've created some hoops to be able to even administer the vaccines. All of our providers have to enter into a provider agreement in order to be able to obtain the vaccines and deliver them. And it raises questions as to whether the provider themselves have to administer the vaccine or an auxiliary healthcare professional can, which raises a lot of logistical problems because most facilities do not have a provider in them 24/7. Also recommend going back and exploring some of the alternatives to incarceration, be it eliminating, if someone can be on work release, why can't they be on home arrest? Eliminating some of those. If they're on a weekender sentence where they have to come in for 20 straight weekends, can you postpone it somewhat? And apply pressure generally. on the communities to do a better job in providing their mental health and substance abuse treatment in the community, so that those individuals suffering from those receive the treatment that they require and deserve prior to it becoming a situation with incarceration. Jails weren't meant to take care of sick people, and being sick is certainly not a crime. Unfortunately, we can't control that care that's given out in the community. We just have to treat the patients that we receive. Hopefully I complied with your 5 minutes, Katti. And
that was perfect. Thank you so much, Tom. So we have a ton of questions, but I want to start here. There's been a persistent and worsening nursing shortage. Getting clinicians, physicians, et cetera, into correctional healthcare has always been a challenge. Would you address that, just your workforce in this moment?
Oh, certainly. It's been a strain. Fortunately, the vast majority of our staff are holding true to their innate desire to help people. That's why they entered into a healthcare profession, and they are working diligently and picking up additional hours. But we have had part-time workers not sign up for a shift since March. We've had a number of people who have their own risk factors and family members that do that refuse to come in, and again, you can't question them, but it does pose a significant strain. We've had a number of staff members who are out with COVID, and depending on what state you are, the restrictions for getting them back to work can be extremely onerous. So it is a concern. We've had to offer additional pay, bonuses, increase hourly rates to try and attract qualified individuals to help us through this. I mean, even though the population has gone down somewhat, our efforts have increased far more significantly.
Sure. So we're going to go to the journalist questions. Eddie Burkhalter of the Alabama Political Reporter asked this. Do you see institutions breaking their own policies on quarantining incarcerating people, i.e. allowing those not exposed to mix with those who are exposed? And to add to that question, what space is there in these facilities to actually quarantine? What does quarantine look like?
That's a very good question. When there was the reduction in the population, it was much easier to quarantine because we could close down, say, a whole unit in the facility and open that up for the quarantine, which we recommended a 2-phase 21-day quarantine. I don't know that I'd characterize it with people breaking their own quarantine. There are some facilities because of space limitations, it becomes very difficult. I'm unaware of anyone who is knowingly exposing people in quarantine to those who have been cleared. These facilities once it's in their facility, they're taking it extremely serious. I think the facility as a whole recognizes the problem it poses. When I say getting people to follow, it's more isolated individual acts that can pose a risk, not the facility, not trying to the best of its physical ability adhere to the recommendations of the CDC.
What does a 21-day quarantine look like? What is that?
It would be, you would come in and again be in a segregated area of that facility. You would eat with only those individuals in that facility. You would have out time only with those individuals. Our care, when we go and take daily temperatures, any other care rendered would be done on that facility. And you stagger it so that you have different areas. Obviously, once you move to a different area, there needs to be and is significant cleaning that goes on, both pre and post that area being part of either the first 14 days or the subsequent 7 days. So it's as though you're sort of moving them through a transition period. The idea of quarantining is not foreign to correctional facilities. Everyone typically is quarantined for the first 72 hours. until we can get confirmation that they don't suffer from tuberculosis. So it's just was an expansion of that process for a longer period of time.
This question is from Grayson Danger, I'm sorry, Grayson, who is a contributor at Forbes. He asked, what COVID-related outcome data and in normal times other mental and physical health outcome data does PrimeCare Medical and its subsidiaries share with public health agencies?
All of the COVID-related tests are provided to various departments of health, depending on whether there's a local one and a state one or just a state one. The mental and physical outcome data, I'm not sure specifically. Again, HIPAA precludes a lot of sharing of that information. We provide significant statistical data to our own facilities, broken down by you throw out something that might have occurred, the percentage of people that are on psychotropic medication, the people who were on suicide watch, the number of extractions were done. That is provided on a regular monthly basis to all of our facilities.
This question is from Tristan Castro, who is a freelancer. How do you expect the new administration to address and perhaps change treatment that's provided to inmates? And perhaps even what is on your wish list for this new administration?
We don't have enough time. I anticipate, I was not a political science major, but moving to a Democrat liberal administration, it's our expectation and our hope that there will be more efforts shown on some of those issues that I identified long-term, the mental health, the substance abuse, putting more resources in the community that way in those areas so they're not needed in a correctional facility. I believe once given the voice, we're going to get some probably, it will be clearer guidance in what to do with this. And I hope that coupled with the time and people recognizing it's not going away on its own will improve our own personal activity and conduct so as to hopefully lead to the diminishment of this virus. And then certainly I think as strongly as President Trump has and did, I think there will be a push to get the vaccines out as quickly and thoroughly as possible, given manufacturing limitations. But he ran on a program very heavily laden with COVID, and I don't believe that's going to change unless the disease is taken care of.
This question is from freelancer Tom McMorrow. Are you able to share actual numbers from some of your facilities of the spikes?
I don't have at my disposal actual numbers. I do know we had a facility that lost a number of their security guards to it, to the extent that they could not safely run the facility, and those individuals had to be transferred to a neighboring facility. But we've had in facilities, again, 7% is our normal percentage of positives. We've had, unfortunately, a handful of deaths related to it. I could break it down other than the percentages. Some facilities, larger, more movement, are above the 7%. We've never approached anything close to like 50%. And again, similar to the community, most of the positives are asymptomatic.
This is from Brittany Haler of the Pittsburgh Current. Has solitary confinement exacerbated or contained the spread? Are systems over-relying on confinement in regards to quarantining and social distancing?
There's still restrictive housing going on for individuals that violate a rule. Solitary confinement is rarely, if ever, used in my experience. And I'm sorry, the second part of that, it is the quarantining or isolation going on too much. That's a difficult question to ask, because I know the isolation or the quarantine plays a role in people. It does in the communities. When facilities are shut down and you're staying more at home, we see all the studies leading to it's creating more mental health problems. And the same is certainly true in a correctional facility. And it is exacerbated there because there's sometimes a lack of communication. So you're not only worrying for yourself, but you're worrying for your loved ones on the outside. How are they dealing with this? So you have to balance that. And we have taken steps recommending daily phone calls for those individuals. Again, getting back to out of cell time. At the beginning, I think that was significantly diminished, and we came up with, do them in groups, do them on different tiers in a correctional facility. Lower tier stays with themselves, upper tier stays with themselves, to try and combat that. We've also sent our mental health workers out in the facility on a regular basis so that they can hopefully connect with someone who is suffering and provide individualized care to that individual.
This is Erin Morrison from the Associated Press. Would you talk a bit more about what's being done to compensate for the loss/reduction of rehabilitation programs, group therapy, faith services? Have you been able to draw a correlation between a decline in the health of patients and the loss of rehab programs? If not now, will that data be available in the future?
I have not, the mental health is a concern. I don't know that we can get down to a granular level that it is associated with the loss of treatment programs. In most facilities, county mental health will handle the programs, and we are individually involved with the individual treatment of the person. Again, I don't know that. I certainly don't statistically feel comfortable trying to draw a correlation. I can tell you it's had an impact on everyone's mental well-being. So we do not typically see a decline in the medical health once someone comes into a facility. So I don't think it's had an impact on that, but certainly the mental health is a concern.
From Tristram Corton, who is a freelancer, would you please explain more about the increase in abuse patients have experienced, if you peel that back some?
Abuse out in the...
I presume Tristram is talking about the substance abuse, et cetera, that you alluded to earlier?
Yeah. Like I said, the how we can gauge it, we have, again, I can provide statistical data on the number of people that come in and go through detox for a variety of substances. We have seen those statistics go up through the last 6 months. We've seen an increase in the polysubstance abuse, perhaps due to lack of availability of drug of choice. But the most remarkable change is the significant alcohol detoxification. That has gone up more than double what we would typically experience or see.
And this question is from Kareth Gabriel of the Philadelphia Weekly. What preventative measures is PrimeCare providing for the inmates in the facilities they serve? PPE, sanitizers, not so much training, but tangible physical things that incarcerated folks are receiving once admitted into the facility.
PrimeCare is not providing the PPEs, but all of our facilities, all inmates are provided with masks, regularly changed, to be kept. Unfortunately, when they're out of cell, when they're in cell, we've had some instances where people with the masks that you tie behind or tie on have used those to try and commit suicide. So you have to watch that carefully. All of the facilities have significantly increased the sanitation of the facility, as well as the frequency with which, as I mentioned, if someone goes out, getting new clothes, more access to showers, more access to personal hygiene. We've also provided mental health newsletters to all of our patients to try and provide additional education as to coping skills.
Thank you so much, Tom Weber. That's all the time we have. Tom, you are in these journalist Rolodex. They will have your email address. You should expect some of them to follow up. We so appreciate your time and all of this information. Okay?
All right, everyone stay safe.
All
So
right.
let me just add, thank you, Tom, very much. We have some questions that are still overhanging. So those that we haven't been able to ask Tom, we'll bundle as we usually do and put them in a separate note to you. So you can answer them separately, and then we'll get that out to our journalists.
All right, thank you.
Again, and we'll take a 10-minute break, and we'll come back for our next session at approximately 12:55. Thank you all.